So my name is Dr. Wijemann. I'm a locum consultant community paediatrician at Evelina in the Mary Sheridan. So thank you to all of you for coming. I'm going to be talking today about fetal alcohol spectrum disorder. What I was thinking is if you just post any questions you have in the chat, I will have a look through and then address them at the end of the presentation, just because hopefully we'll cover it as I go through. If I'm talking too fast or if there's any audio issues, please just send me a message through the chat. So just to go through the aims and objectives of the presentation. So I'm going to talk to you a little bit about what fetal alcohol spectrum disorder is. We'll go through the causes of this. We'll go through the presenting features, how we diagnose fetal alcohol spectrum disorder, and then talk a little bit about management as well. So if you've logged into menti.com, what you should be able to do is enter free text about some of the features of fetal alcohol spectrum disorder. So I think you can have about 3 turns, and I'll give you a couple of minutes. And basically, if you just want to type in any of the features, and then it should appear here on the screen. Brilliant. So dysmorphic features, great. Behavioral problems, that's great. Developmental delay, brilliant. Microcephaly, flat philtrum, brilliant. Keep going. Smooth philtrum, yep. Learning difficulties, low body weight, ADHD, wonderful. Poor coordination, that's brilliant. So you actually know lots and lots, which is brilliant. And yeah, if you just, I'll give you another minute if you just want to enter anything else. So yeah, but someone's written IUGR, which is brilliant as well, and low body weight. Great. Short stature as well. Right, so I'm going to move on to the next slide now. So yeah, so what I want to do is this might be some of the things that you think of when you think about fetal alcohol syndrome or fetal alcohol spectrum disorder. So as you can see in this picture, we have the indistinct smooth philtrum, short nose, low nasal bridge, and then as some people quite rightly said, microcephaly as well. You can't really say from this picture, but growth, small head circumference, small eye opening, and also a thin upper lip. So I think if anybody hasn't muted themselves, if they could just mute, that would be great, because I think there might be an echo. Sorry about that. My screen's just frozen a little, but we'll keep going. So we've got another question now. So again, if you go to menti.com, put in the code 754005, which is at the top of the slide. And I just wanted you to vote for this question. So what is the minimum amount of alcohol consumption in pregnancy that can affect a growing fetus? And it's all anonymous, so you don't have to worry. And I'll give you guys a little bit, because there's 40 of you, I'll give you some time. If anyone who's coming in can just mute, that'd be amazing. Thank you. Great. So I can see, I think about 14 of you have voted. So again, if you can just go to the website at the top and enter the code. Okay, I've just got a message through on the chat. Okay, brilliant. And I'm just going to give you just one more minute to vote. Okay, so I'm just going to show you the correct answer now. So yeah, so all of you who said any amount were correct. So yeah, this can be a bit of a surprise when you first start reading about fetal alcohol spectrum disorder, and it was definitely one of the things that I didn't realise, because I always thought you've got to have a certain amount in order for the fetus to be affected. So essentially no amount of alcohol in pregnancy is known to be safe. So sorry about that, just skipped ahead on the slides. So historically, people have thought that of alcohol exposure in pregnancy in terms of dose, so that the more you have, the worse the fetus will be affected. And we've thought about it in terms of what the strength as well, in terms of how much alcohol you use and what type of alcohol, and also the timing. So historically, people may have said, oh, it has more of an effect in the first trimester when the fetus is developing more rapidly. But actually, what we know now is that there's lots of factors that are really important when it comes to alcohol exposure in pregnancy affecting a fetus. So, for example, the nutritional status of the mother and genetics, which affects how the mum metabolizes alcohol. So it means that for one woman, a couple of glasses of wine a week might be absolutely fine, but might be devastating to another woman's baby. And what we know is that moderate levels of alcohol actually disrupt the molecules critical for brain development. And what we'll see as I go on in the presentation is that that then is key in terms of the symptoms that children with fetal alcohol spectrum disorder manifest with. So within the brain, there's an L1 cell adhesion molecule, and this can actually be disrupted by the amount of alcohol in just one drink, so relatively small amounts. And what we know is that in children who have developmental delay and brain malformations, they have mutations in the L1 gene. So then it would then, you could hypothesize from that if alcohol affects the adhesion molecule in the same cell, you're going to have difficulties with brain development. So I just wanted to talk a little bit now about the evidence surrounding that. So there was a study in 2012 that looked at prenatal alcohol exposure and growth deficiencies. And what they found was that there was reduced birth length and weight, microcephaly, a smooth philtrum, a thin vermilion border, and that was associated with the timing of prenatal exposure. So effects were dose-related, and there was no evidence of a threshold. And there have also been studies both in the UK and in Queensland. So in the UK, there was the AUSPAC study, which is the Avon longitudinal study, and had about 7,000 children. And the study in Queensland as well was, again, a really big sample size. And what it showed was that moderate alcohol consumption in pregnancy was associated with lower academic performance in children. And so what this suggests is, even if every child won't have the full-blown fetal alcohol spectrum disorder, even small amounts of alcohol can actually affect IQ, brain development, and academic performance. So this is just a diagram just to show the prenatal structures, the brain structures which are most sensitive to prenatal alcohol exposure. So one area is the corpus callosum. So we know that that communicates motor, sensory, and cognitive information between the two hemispheres of the brain. So if you can imagine, when this becomes affected by alcohol, that can lead to storing and retrieving information problems, difficulties with problem solving, and difficulties with attention and verbal memory. And so that's what we see when children present to us. The other area that can be affected is the cerebellum. So what we know is that, again, if prenatal alcohol exposure can damage the cerebellum or affect the development of the cerebellum, this can lead to difficulties with controlling movements, maintaining your balance, and your fine motor skills. And again, just thinking about what might come to clinic, most of the time children won't come to clinic necessarily with that question about fetal alcohol spectrum disorder, but they may present with these non-specific difficulties with movement, balance, or fine motor skills. So I wanted to just talk a little bit about all the different terms, because when you start reading about fetal alcohol spectrum disorder, there's lots and lots of different terms. So one of them is fetal alcohol effects, which means that your behavior and cognitive function are affected by alcohol, but you don't have all the facial features, and your global cognitive function is preserved. There's also another term you might read about, which is alcohol-related birth defects. And then there's another term, again, that's often used in America, that's alcohol-related neurodevelopmental disorder. So it all gets quite complicated. And then you also have something called partial fetal alcohol syndrome. So this was a term used in the past when you might have some of the effects of alcohol, but you wouldn't have all of those classic facial features like the smooth philtrum, microcephaly. And then there's also a term that's sometimes used, which is neurodevelopmental disorder prenatal alcohol exposure. And what's happened in the last few years is that some guidance came out from Canada, which actually removed the growth criteria and also modified the domains of neurodevelopmental delay, which I'll talk about. And currently at the moment, they're actually developing some NICE guidance, and there's also some guidance on fetal alcohol spectrum by SIGN, which is the Scottish version of NICE, and that's what the NICE guidelines will be based on. And that's a really good resource, which I'm going to talk about later in the presentation. So this is just a picture of the typical sort of fetal alcohol spectrum disorder with what we call Sentinel facial features. So as you can see, he's got the small eye openings, a very smooth philtrum, and a thin upper lip. And so that's one of the terms that's now used. And then the other term that's used is FASD without sentinel facial features. And this was something that initially I didn't quite realize, because I'd always think about looking for the facial features, but not the fact that actually that's only part of the story. So to make this diagnosis, and I'm talking about this based on the SIGN guidance, you have to have confirmation of prenatal alcohol exposure. You have to have evidence of severe impairment in 3 or more of the neurodevelopmental areas of assessment, which I'll talk about. And So this actually was quite a big surprise to me. And what it really highlights is it's really important when you're doing your developmental assessments, or even if a child presents to clinic, maybe not even a community clinic, but a general clinic with some of the neurodevelopmental features, to ask about prenatal alcohol exposure. And a lot of studies have shown that we're not very good at taking alcohol histories. So these are the 10 neurodevelopmental domains that we need to think about in fetal alcohol spectrum disorder. So one of them is around academic achievement, attention, cognition, the thinking and the reasoning, around language, which might be expressive or receptive, memory, and then one of the really big ones, which parents talk a lot about, is the ability to control emotions. And I'll be going on to talk a little bit about patient experiences, but this one can be quite a big one. So what you might find is the child comes with behavior difficulties or difficulties concentrating at school. And that's how that emotional regulation will manifest. And the other thing is that children can have really big meltdowns, so they can go from being really, really happy to suddenly having extreme anger. The other areas that are important to consider are executive functioning. So that's not just thinking about academic tasks, but also thinking about our day-to-day tasks, organizational skills. Can a child pack a bag for school? Can they get themselves dressed and get everything in the right order? And we've got motor skills. And then the other big area is social skills and social communication skills. So a lot of the time, you might get a referral to community pediatrics about possible autism or possible ADHD. But this is why it's so important to ask about prenatal alcohol exposure. And then the other area where there can be difficulties, not in all, but in some children, is in the actual brain structure itself. So one of the really important things to remember is that fetal alcohol spectrum disorder is brain-based. And what I'll do is I will send the organisers a PDF of this slide, because I know that it's a little tricky to see. But what's really important when thinking about these children is it's not that they can't, it's not that they won't do certain things, which is often the case. So you may get a referral either from the GP or from school saying they're very defiant, they're really oppositional, they're very impulsive. But when it comes to these children with fetal alcohol spectrum disorder, they genuinely aren't able to control some of these impulses. So just to think a little bit about basically thinking about our brain anatomy and then how that manifests in children. If you think about the amygdala, that's your ability to regulate reactions, to regulate your emotions, to make good decisions. So if that's affected, that's going to manifest in your behavior. And then if we think about the basal ganglia, that's going to affect all your motor behaviors. It's going to affect the way you process your movements, and it's going to affect your cognitive functioning. And then if we think about our frontal lobe, that's an area that's really important for executive function, coordination, storing your memories. So all of these areas can be affected. And then if we think about our hippocampus, that's our ability to form new memories. And if you remember back to the 10 domains, memory is an area that can be affected in FASD. And then if we think about the parietal lobe, that's your spatial awareness, your mathematical ability, and dyspraxia. So again, the child may look completely normal because they may not have these facial features. But when they're having these behavioral problems or when they're struggling in class, it's really important to think about, actually, it's not that they won't do this, it's that they really genuinely might not be able to. And if you think about those 10 domains, it's affecting almost every single area. So it's not just one single area that's affected. So what I'm going to do now is I'm just going to play 2 videos just to help you get an idea of what it's like for children and families with FASD. And I'm just going to, I'll post the link in the chat in case you can't hear the one that I'm playing. If there's any issues, just send me a message through the chat. So, just sorry everyone, the video is just struggling to load. I'm just going to try and So I'm just going to pause there and move on to the next video. So I'm really sorry if it froze a bit for you. I was just having some connection difficulties. I'm going to post the link for the next video in the chat, and then I'll also play it through my presentation as well. And so the reason I wanted to share these was just really just to help you understand a little bit about what it might be like for a child with FASD. And and obviously, as you saw with the first child, Nicholas, he has short stature. He had the microcephaly. He talked about how he's unable to play sports even though he really enjoys it. You could probably hear that he talked very fast as well, and that he was quite impulsive. Um, so the other area where FASD comes up a lot is during adoption. And if you read it, probably if you read a little bit more into it, there's a lot of adoptive parents who maybe didn't know the mother had been drinking during the pregnancy, and so then this is something they've had to deal with as the child has got older. So this is just a little bit of perspective on that, and also the perspective of a slightly older person. So sorry about this. I'm just going to pause it and see if it will load. Or if you want to try following the link I posted in the chat, please do that. So I'm just going to try to reload this. So we'll try that. Great. So I hope everyone was able to hear that. And I think that video is a really good example of how FASD can affect children and young people in so many areas of their life, and it's also lifelong. So again, if you think about what Sam was talking about, and then think back to those 10 neurodevelopmental domains, so things like his impulsiveness and attention difficulties obviously led him to get in a significant accident. You can also see that it's harder for him to work. So for example, doing his job, he will struggle to pay attention on tasks. And you can also see it from the parents' point of view as well. So for the adoptive parents, having to deal with not just the difficulties of adopting a child, but then all these different neurodevelopmental difficulties, and the fact that it's all there all the time, it's going to be there forever, and it can be really, really unpredictable. So I think what can be really helpful when you're assessing these children and families is thinking about what life on a daily basis will be like for them, both for the family and for that child as well, and how you as the community paediatrician can look at supporting them in those areas. So I just wanted to talk a little bit about what to do when you're thinking about making a diagnosis. So depending on where you work, there are different sort of centres and different ways in which they diagnose FASD. So within the UK, there's a specialist clinic that's run in Surrey that's a sort of tertiary level service by Dr. Raja Mukherjee, and he's a consultant psychiatrist and an expert in the area. So he runs a clinic with members of the MDT where they actually do a 2-day assessment for children. It's got about 12 hours of assessment where they look, in addition to all the facial features, at those neurodevelopmental domains. But as you can imagine, it's really expensive, and referring into that clinic can be really tricky because depending on where you work, your CCG has to fund that. But there are other models that can be used. So, for example, in Scotland, they've set up a service. So when thinking about making a diagnosis, especially thinking about babies, but also when the young person gets older as well, to document any growth impairment and any other birth defects. Another really important area to consider is genetic causes. So I had a 10-year-old girl come to my autism clinic, and her mother had always been very honest early on that she drank during her pregnancy. But this particular child also has a chromosomal deletion. So she has a chromosomal deletion in it's 15q11.2, which is associated with neurodevelopmental delay. And so one area that was really important was to speak to a geneticist. So before we can think about giving this diagnosis of fetal alcohol, and she actually she doesn't have the facial features, but she has probably all 10 of the neurodevelopmental domains. It's really important to also consider genetics. So last week I did a joint clinic with the geneticist to try and talk about how much of her neurodevelopmental presentation could be due to this deletion and how much could be due to alcohol. And essentially what the conclusion was that it's probably both and it's multifactorial. But just a really important thing, so with the clinic that they run in Surrey, they won't accept the child unless they've had an erased CGH. So the other things to think about are hereditary causes, prenatal and postnatal factors. So just your general history taking that you would always do in terms of so whether there were any neonatal difficulties, any childhood illnesses, and also thinking about other social factors, so any history of trauma, for example. So just wanted to talk a little bit about neurodevelopmental assessment and what we think about. So, apologies. So these are the different areas we look at. So again, it's thinking about those 10 domains. So with this 10-year-old girl that I saw in clinic, she came first of all to a general developmental clinic when she was about 3.5 years old. And when she was about 3.5, she had a developmental assessment which showed that she had language difficulties. Then a couple of years later, she came back because she had fine motor difficulties, and there was a query about whether or not she's got dyspraxia. So she was seen by an OT, and one of the things OT said was that she had big sensory regulation difficulties. So she would feel as if people were touching her when they weren't touching her. She was extremely sensitive to different clothes she wore. And then a couple of years after that, she had attention difficulties and she ended up getting a diagnosis of ADHD. And then finally, she came to my autism clinic just last year and she ended up getting a diagnosis of autism. And so when I was thinking about this child, I was thinking, wow, she's got so many different diagnoses. The other issues were that she was in school, she had an EHCP, and actually she had significant learning difficulties and memory difficulties. So at the age of 10, she wasn't able to dress herself. She would struggle to get the order of things right. She needed constant supervision, both at home and in school. So when I was thinking about this child, I was thinking her difficulties can't just be explained by ADHD and they can't just be explained by autism. There's something else going on. So this is why neurodevelopmental assessment is really important. So thinking about diagnostic tools. So in an ideal scenario, you would want to have what we call direct standardized measures. So for example, you'd want the child to have a cognitive assessment with an educational psychologist. You'd want her to have an ADOS and DISCO or ADIR, which are the interviews for autism. But in reality, depending on where you work, it may be difficult to have all of these direct measures. And so actually, when I went to a study day on FASD with this Dr. Mukherjee, he talked about use of indirect measures as well, because in reality, it can be really difficult to get funding for all of these. So if you are going to use indirect measures, it's really important to get information from multiple sources, so not just one source. So this is a slide which just goes through a sort of algorithm in terms of diagnosis of FASD. And again, I'll send a PDF of these slides, but this is also from the SIGN guidance. And it's quite good just to get your head around how to diagnose. So the key bit is to think about whether or not there's been exposure to alcohol. That's your first step. And then you think about your facial features. And then basically you can go through the algorithm depending on whether or not you have your facial features. You then go onto your CNS criteria, which are the Neurodevelopmental Domains. And then you can basically follow the algorithm down to help you either make a diagnosis or decide whether or not the child is at risk. So I wanted to touch on why diagnosis is important. So there are some people who will say, well, if the child's got a diagnosis of ADHD or a diagnosis of ASD, why do you also need a diagnosis of FASD? But actually, when you talk to the families and when you look at what families say and children say, it's really important because it helps to sort of put together all of those different difficulties. And it's really important to both for parents and the child to understand, but also for teachers as well, because their child won't fit the profile of just ASD or just ADHD. So it's really important for the child and the family. And it's also important for the parents so that they understand that those difficulties are due to the alcohol exposure and it's not because of their parenting, which can often, may often be the case and maybe what people say. It's also important to access support service and early intervention. So we know with all of these neurodevelopmental difficulties and developmental delay, early intervention is key. And it's also really important for teachers as well. So as you can imagine, teaching a child with FASD would be really challenging because you have to consider attention, social communication, and the impulsivity. So it would be really difficult, and they may have meltdowns, they may really struggle with their emotional regulation. So you could see how teachers may think, oh, they're just being difficult. So that's really important for teachers. And as you can imagine, because it's not that common compared to autism or ADHD, teachers won't necessarily have much knowledge. So it's really important for them to be educated. And it's also important to raise community awareness and to challenge social norms. So depending on different cultures and sort of the society view, there will be different social norms around drinking alcohol. So I imagine a lot of people would say, oh, it's fine to drink a glass of wine or two. My doctor recommended it. Even for me, before I learned more about this, I didn't realize how any amount of alcohol could affect the fetus. And again, going back to understanding behavior. So it's not that a child won't, but it's that they can't because their brain is different. So this slide is just to give you a little idea about some of the strategies teachers can use. So if you look at the top right, so this is taken from some Canadian guidelines in Manitoba. So they have a large native population there, and there's a lot of fetal alcohol spectrum disorder seen there, probably partly a genetic component. So as you can see, these are visual timetables because children with social communication difficulties and FASD process things much better visually. There's also timers, which are really good for transition. So that's something that you see in autism, but particularly good in FASD. One of the things that's really difficult for children with FASD is because of their sensory difficulties and all the attention and social communication difficulties, they can get really overwhelmed by the environment. So if you imagine a really noisy classroom of 30, so they need opportunities to calm their nervous system, so sensory tools, strategies. You can see here on the lower left corner, using organized shelves and color-coded binders can really help with visual clutter, because although these children are more visual, also if they're overloaded visually, that can be really challenging. So those are just some of the strategies, and lots of countries have developed this guidance for teachers on FASD. So I just wanted to, just coming to the end of the presentation, talk a little bit about conditions that coexist with FASD. And so basically the bottom line is there's a lot. So there was a study done in 2016 in America that found over 400 conditions associated with FASD. And of course, that's just an association rather than necessarily causality. But they did look at 127 studies, which showed that, as you can see, there were difficulties across so many systems. So CNS, vision, hearing, cardiac, GI, and respiratory. And they did meta-analysis of 33 studies, which indicated that 90% of individuals with FAS had conduct problems. So, and again, you can see how that may be the case when you think about those neurodevelopmental domains. 80% had communication disorders, 70% had cognitive disorders. So again, when you think back to life for those parents and life for that child, it's going to affect them throughout their schooling and as they get older. And that's why, again, it comes back to early diagnosis and intervention is really important. Again, attention deficit and hyperactivity. So as some of you probably know, ADHD itself can be associated with higher risk of criminal exploitation. And so again, that's something that's really important to think about. The other issues to look at are hearing loss. So this is just comparing to population, but hearing loss was 129 times more frequent and blindness 71 times more frequent. So again, as we do with all children, when we think about development, it's really important to consider hearing and vision. And I guess one of the key take-homes for this is that you're not necessarily going to see the child come to your clinic as a query of FASD, but if, for example, you're seeing a child with hearing loss or with blindness, or they've got these cross-system effects, it's important to think about alcohol as a cause and ask about it, even though it can be a really difficult subject to ask about. Also, if you want to sort of look into this a bit more, you can go to the SIGN guidance for fetal alcohol spectrum disorder, which is the Scottish guidance, and they've got proformas to use for FASD and a proforma for alcohol history taking, because what we need to ask about is not just the yes or no, but how often were they drinking and what were they drinking and how big were the measures. So again, just to sort of really finish on what's really important. So what's important is that these children do, like all children, have so much potential, but it's really important to know how to unlock that potential. So when we think about how the child might be affected, we're thinking about their cognitive function, adaptive behavior, executive functioning, sensory integration, social communication, all of those things that you need to live an independent life, and to be a part of society. So all of those can be affected. But this is from Scotland. They talk about keys basically to unlocking that potential. So being really concrete and being consistent, repeating things, having routine and structure, which is really important for ASD, also for FASD, being very specific about what you want, so the children don't feel overwhelmed, and also having structure and supervision as well, because these children will be more vulnerable. So just to summarize, as we're coming to the end of the presentation part, any amount of prenatal alcohol exposure can affect the developing brain. And just because you don't have the facial features doesn't mean you won't have FASD. So it's really important that even if the child may not have those facial features, you consider it as a diagnosis, especially when you know there has been prenatal alcohol exposure. And early diagnosis and intervention can change outcomes. So I think that I've got to the end. So either you could post any questions in the chat, or if you want to unmute and ask me, that's fine as well. So I've just had a look. So I think we've got one question about is there a minimum amount of alcohol? So no, it's just any alcohol, because it depends on the woman's genetic structure and how she processes alcohol. And yes, the diagnostic algorithm is available on the SIGN website, which is the Scottish version of NICE. So you can go there and access everything. So yeah, I will just be silent for a little bit. And if there are any more questions, just feel free to talk or to post them in the chat. Okay, brilliant. So any tips on raising an FASD diagnosis with parents without making them feel at fault? So thanks so much for that. It is really tricky. I think so the mother I saw, she had so much guilt. She'd been drinking early on in the child's life, and then she had social care support and had stopped drinking. So she kind of asked me that question and brought it up with me. And I think that the important thing that I try to say to parents is it's kind of focusing on the now, and it's about how you can help and support the child now. So with that particular mother, what I talked about was how she'd really come so far because she'd stopped drinking, she'd gone through a traumatic upbringing herself. So I really tried to focus on the present and the future, and the fact that by coming to the appointment and raising this with me, she was taking responsibility for her child and supporting them. The other thing is, when I ask about alcohol and any history along with drugs and smoking, I just sort of say this is something that we ask everyone, and it's really important because it will help me to make a diagnosis about your child. And often parents have a lot of guilt about it, so it's just a lot of reassurance, because I think in all of these cases, no one is doing it intentionally, and if they knew what the consequences were, they wouldn't have drunk. So it's just about being non-judgmental. So another question we've got is about who can officially make a diagnosis of FASD once we've gathered all the information. So I think this will really depend on where you work. So with me at Evelina, I basically have been discussing it with the clinical lead. So I think in the scenario of the case that I was talking about, actually, because professionals had done all of the assessments, there would be no need to send her to the tertiary clinic. But what was really important in the case I was talking about was getting that genetics opinion. So What I would say is, because it's going to differ depending on where you work, is to sort of talking with your MDT about the feasibility. So depending on how big your department is, it might be that early on you say, actually, I have a strong suspicion about this. Shall we refer them to the tertiary clinic? On the other hand, you might be able to do a lot of those assessments in-house. Another good resource is I'll send this to the organisers and then they can send it around to you. But there's a really good website that's called NOFAS, which is NOFAS, and that's been organised by a parent, and that has really good information, both for professionals and for parents, about talking about alcohol and about how to sort of destigmatize talking about alcohol and pregnancy. And the sign guidance from Scotland is also really good. So I think we're just coming up to 2 o'clock, but I'm happy to wait for another minute. If you do have any more questions that you do want to ask, you can always email. I think it's Katie and Emma who are organising the week, and I'm happy for them to get in touch with me, and then I can write it back to you. But I really hope that you've all enjoyed it, and I'm guessing that Katie and Emma will send around feedback, so any feedback at all would be brilliant, and I hope that technically everything went okay as well.